Good morning. My name's Jamie Whitehorn. I'm a consultant in infectious diseases and microbiology at Addenbrooke's, and I'm talking today on the 9th of January about the use of antibiotics in COVID-19 patients. So it's a very short presentation, really. There's a few key messages to take home. One is, the first thing is to say is that we don't recommend the routine use of antibiotics in COVID-19 patients unless there are features that suggest a concurrent bacterial infection. Most patients who present with COVID acutely do not have a bacterial superinfection. The data suggests that less than 10% of patients have an additional bacterial infection when they present with COVID. What is difficult is that persistent fevers and elevated CRP are very commonly seen in COVID-19 patients, and these do not necessarily indicate a bacterial infection. In these situations, procalcitonin can be a useful adjunct when it is difficult to distinguish between bacterial infection or COVID-19 infection, and that may be a useful test to use. Obviously, some patients will have bacterial infections, and these may be suggested by people who have purulent sputum or evidence of lobar consolidation on their X-ray, or other features that may suggest that they have a bacterial infection. In these patients, we'd recommend that appropriate samples are taken, such as blood cultures, sputum cultures, and urinary antigen tests for Legionella. And then if antibiotics are to be used, we'd recommend prescribing as per the CUH antibiotic guidelines for respiratory infections. There is no indication to do anything different to what we would usually do for a community-acquired or hospital-acquired chest infection. One thing to note about the antibiotic guidelines that we're using at CUH, we're encouraging short courses of treatment. So 5 days is the general standard treatment we recommend for a chest infection, and these should be used in situations where antibiotics are to be used in these patients. Obviously, patients who are in hospital for a long time, particularly those who are admitted to HD or intensive care, are vulnerable to getting hospital-acquired infections, either affecting their chest or possibly line infections, and those require more thought and, again, the use of our guidelines that we recommend. We're very happy to be contacted either in infectious diseases or in microbiology about specific queries regarding these patients and about their management. Thank you for your attention.